All right, the time has officially turned 7 o'clock, so I would like to say hello and thank you all for joining us for tonight's Musculoskeletal Health Australia's webinar, Gout, Your Questions Answered. My name is Helen Jentz and I'm a member of the team here at Musculoskeletal Health Australia. I'd like to take this opportunity to acknowledge the traditional owners of the lands from which we are joining the webinar this evening. MHA is beaming this webinar to you from the lands of the Eastern Kulin Nation, and we pay our respects to the traditional owners and custodians of these lands. We acknowledge and uphold the traditional owners' continuing relationship to the land and waterways and pay our respects to their elders, past, present and emerging. Before we start officially this evening, I'd like to go through a little bit of housekeeping. We will have the chat function open and the Q&A function open throughout the webinar, and it is being monitored. So feel free to put any questions or comments in the chat and we'll endeavour to discuss them in the Q&A part of this webinar. Also, if this evening's webinar raises any concerns for you personally, please make sure you contact Musculoskeletal Health Australia's back pain, arthritis and musculoskeletal conditions, or as we like to call it, BAM, helpline on 1800 263 265 and speak to one of our highly qualified healthcare professionals. So, for tonight's webinar, we're delving into gout. When preparing for this evening's webinar, I decided to do a bit of a straw poll and, of course, ask family and friends what they knew about gout. Now, here are some of the interesting facts that they came up with. Gout only affects wealthy people. Gout is a bloke's disease. Gout always attacks the big toe. Gout is caused by eating too many rich foods and drinking too much alcohol. Gout isn't serious, and it will always go away on its own. I think all of these things we know or now refer to as old wives' tales. At least I'm hoping that's what we refer to them as. And I'm pretty confident that our amazing speaker this evening, Professor Flavia Cicuttini, is going to demystify or demythify these and many other tales relating to gout. So a little bit about Flavia. She's the head of the Musculoskeletal Unit at Monash University and the head of Rheumatology at the Alfred Hospital. She holds specialist medical fellowships from the College of Physicians in Rheumatology and Faculty of Public Health. Her principal research interests are the prevention and treatment of musculoskeletal diseases. She has published over, now wait for it, 600 peer-reviewed manuscripts, including journal articles and book chapters. She is an amazing presenter, an amazing doctor, an amazing researcher, and an amazing health advocate. And we are extremely privileged that she's been able to join us this evening for tonight's Gout, Your Question Answered. Welcome, Flavia.
Thanks a lot, Helen. After that introduction, I'm not sure I should give a talk. But anyway, thank you. And thank you, everybody who's been able to join us tonight. So what I'd like to do, I tested this before. Oh, yeah. So what I'd like to do is really talk to you a little bit about gout, who gets it, talk about uric acid, think about how gout presents, both acute gout and chronic gout. What are we really trying to do when we treat gout? What do we need to do to be able to treat gout? And what are some of the barriers to good gout management and how we might overcome these? So they're the general themes today. So what is gout? So gout is a painful type of arthritis. It's the most common form of inflammatory arthritis, but often people forget that it can also affect other organs like the kidneys and the heart. So who gets gout? Men get gout more than women, and it gets more common as we get older. But certainly women after post-menopause start to get more gout. And we do talk about gout in the big toe. That's one of the most common presentations, but it can really affect any joint. So how do people present? We've got acute gout, where people present with a very painful, red, swollen joint, and often this is self-limiting over about a week. But chronic gout can also start to develop, where you start to see damage to joints, the kidneys, and also effects on the heart. When uric acid crystals get deposited, you can also end up with these tophi, which are these clumps of uric acid crystals that can damage joints over time. And so you get chronic ongoing pain, and also lumps that become big enough that they actually burst through the skin like bits of chalk. So gout is due to a buildup of uric acid in the blood. So uric acid crystals form when the uric acid levels in the blood reach above a critical point, and we call that a saturation point. So the uric acid's dissolved in our blood, but when you hit a certain point, you start to see these crystals form. Uric acid is naturally occurring. We all have it in our blood. It's normal and healthy. The problem is when it starts to get high, it may cause gout. Uric acid is produced every day when we break down purines. Purines are chemicals that are naturally created in our body, and they're also present in certain foods. 75% of the uric acid in our bodies is from the purines we break down. And this is what Helen was suggesting, that people talk about as a disease of affluence and what you eat. But 75% is just made from inside of you. It's 25% that comes from food and drink, and we're familiar with certain types of food that are rich in purines, so red meat, seafood. Alcohol can stop us, our kidneys getting rid of uric acid, but certainly beer also is a rich source of these purines. Organs like a liver, kidney, and brain are high in purines. And also one of the things that we've discovered over the last few years is that fructose in sweet beverages is a really big problem. Now, the biggest problem we have with fructose is that corn syrup is a rich source of fructose, and fructose is used in a lot of soft drinks to sweeten them. So the naturally occurring fructose in fruit, and that seems to be less of a problem, but the sweetened cordials, soft drinks that have fructose from corn syrup seems to be the big problem for gout. So basically, an increase in uric acid level is either because our bodies produce too much, or our kidneys don't remove enough. And so we end up with this imbalance where we end up with too much uric acid in our bodies. So along those lines, if we're talking about the overproduction or under removal, when we look at risk factors for uric acid and for gout, then under the age of 65, gout is 4 times as common in men as it is in women. But over the age of 65, it's still more common in men, but it starts to even out. And that's in the postmenopausal population. And so it's not just a disease of men. Often gout runs in families, and this is often due to a genetic abnormality, so people aren't getting rid of enough uric acid in the kidneys, even though their kidneys might be working normally. And it's not uncommon to have someone whose father and uncle and grandfather all have gout. People with chronic kidney disease don't get rid of enough uric acid, so you get a build-up of uric acid. Some medications, like the water tablets, the diuretics, put you at more risk of holding on to the uric acid. And people that are overweight and obese tend to produce more uric acid compared to the amount that their kidneys can get rid of. So just because you have uric acid in the blood, not everybody gets attacks of gout. But if you have uric acid levels that are continuously high, then crystals can start to develop. And when enough of these crystals develop, and you can see some of them in this lower picture, they spill into the joint, and they can trigger this inflammatory response so that the person gets the typical attack of very severe pain and swelling, and we call that an acute attack. So why do you suddenly get an acute attack on a certain day? There is no obvious cause. But what we do know is that if a person has been fasting for an operation, comes into hospital, and they have gout that's not very stable, it will often precipitate an acute episode of gout. An alcohol binge can do that. Suddenly eating a whole lot of very rich food, and a classic example is a barbecue where suddenly people have lots of red meat, lovely red meat steaks and some glasses of beer, and then a day or two later come up with this sort of sudden bad episode of gout. Now, a thing that's important for us to keep in mind is that gout does affect joints, but it can damage other parts of the body, such as the kidneys and the heart. So gout can deposit and create these big uric acid stones, which can block part of the kidneys, causing damage, but also smaller amounts can be deposited throughout the kidneys and damage the kidneys. Gout is an important risk factor for heart disease, and there was a very interesting study in the last 2 to 3 years which showed that if you're sitting at home minding your own business and suddenly have a bad attack, an attack of gout, they're always pretty bad, the acute attacks, that the person who's just had a bad attack of gout is 2.5 times more likely than a person of the same sex and age to have a heart attack in the next 30 days. So when people come to hospital for a heart attack, we don't ask them, have you had an attack of gout in the last 30 days? But a big study looked at people in the community and found that if you'd had a heart attack, if you'd had a bad episode of gout, that you were at increased risk of a heart attack in the next 30 days, which is thought to be due to the very massive inflammatory response that happens as part of an episode of gout. And what was quite interesting is that the risk was still present at 6 months. And so it had gone down, so it was attributed to that episode of gout, and it goes down, but it's still 25% increased risk at 6 months. As well as this acute attack of gout, then there's also gout is a risk factor for chronic cardiovascular disease. So if people have gout, what are the goals of treatment? Then obviously, you know, if someone's got a bad sudden attack, you have to do something to improve the symptoms and get the person up and running again. But the goals of the long-term treatment are to prevent these bad gout flares and the subsequent joint damage, and also to reduce kidney and heart disease. Now, clearly the way we treat gout depends on the different stages of the disease. So obviously acute attacks of gout need a certain treatment, and then to deal with the chronic gout or preventing the long-term damage is a different, complementary but different approach. So acute gout. So a common presentation is Mr. Jones, a 63-year-old man who presents with a painful left foot. His foot is red, swollen, and he can't put his weight on it. He's had similar episodes in the right big toe and the right elbow that have previously improved with naproxen, which is an anti-inflammatory. He also has high blood pressure, type 2 diabetes, and some kidney damage, moderate kidney disease. And you have a look at the toe and it's painful. He's got a warm red first toe that's exquisitely tender. You know, characteristically, people say you can't even let the sheet lean on it because it's so sore. But he also has these nodules, which are those tophi on his elbows. So how should Mr. Jones be managed? And we might revisit it at the end of this talk. So how do we diagnose gout? Often it's due to a typical picture. So in Mr. Jones, he's had previous episodes. That's the likely diagnosis. It's very similar to what's happened before. Sometimes if a person presents with a big swollen knee that's acutely painful and they've never had gout before, then you can't, you know, if someone goes to the doctor can't be confident that that's just gout, because you're always scared, could this be infection in the joint? If it's the first toe and it's a typical presentation, you don't need to have lots of tests. Sometimes if people have had you know, suddenly the first presentation is a big swollen knee, it looks exactly like infection, and often in that situation you have to take some fluid out, make sure that it's not an infected joint. So we, you know, always ask ourselves, what is the cause of this? Is it fairly typical? We use clinical judgment because you don't always need to do lots and lots of tests, but tests are usually done if there's doubt about the diagnosis. You know, usually at some stage you want to make sure that people's kidneys are working okay, that there's no other underlying cause making them at risk of gout. And also, you know, you end up wanting to monitor their uric acid. So treatment for gout. So often acute attack of gout are bad enough that, you know, you do need to do something. Ice packs can help, but often you need to turn to medications. So in many otherwise healthy people, you can use anti-inflammatories like naproxen or Celebrex. Now, as people get older, and you know, you might, if a person already has a little bit of kidney disease or they're on anticoagulants, a lot of people in the community are now on blood thinning medicines. Their non-steroidals aren't a great idea, and we often use some cold gout or colchicine. It's been around for decades. We use it at a lower dose than was used years ago. When I first graduated, you know, people would say keep giving colchicine till the gout goes away or you get diarrhea. Now we just use 2 tablets and then another one in about 6 to 8 hours, and then one twice a day. So colchicine is still used. Some people, if it's a very bad attack and they've got other medical problems, might need either an injection of cortisone into the knee or even some oral cortisone or prednisolone. It's the idea is not to use these long term, just very short, sharp go. If the other medications aren't safe because of other medical conditions. There are some new drugs around, new biologics that inhibit interleukin-1, and they work very well. They're quite expensive, and you don't, it's very uncommon to have to use these drugs. So the acute episodes of gout will often, even if you do nothing, will often settle down on their own, because what happens is that very intense inflammation also helps dissolve and get rid of the uric acid crystals that have caused the acute attack. But in general, it's a very uncomfortable and incapacitating, as any of you who have had episodes of gout will know. So they do get treated. But what about chronic gout? This is where we move from just treating the acute episode to starting people on prevention, gout prevention. So things that many of you will have heard about, allopurinol or Xyloprim is the most common used. It's been around for decades. So the recommendation is that if a person has 2 or more gout flares a day, 2 per year, or people have started to get these tophi, these crystals, it means the burden of gout, of uric acid in the body is very high. And also if people have any damage, so you can often see it on x-rays where you get these punched out, almost like holes in the bone around the joints, which are due to the deposition of the uric acid. These are the types of situations where people should be starting on gout treatment. It's less dependent on whether your uric acid is high, just high on its own, although often people that have had high uric acids will eventually get gout. So the aim of using the gout prevention treatment is to reduce and maintain the blood uric acid levels below the saturation point that produces new crystals. So you have less new crystals and existing crystals start to dissolve. This will also result in less attacks of gout, prevent joint damage, prevent kidney damage, and reduce the risk of heart disease. Now, the current recommendations for managing gout is to start to target a uric acid level. So there's this idea of treat to target. And so for people with gout, it's 0.36. For people who already have joint damage or a tophus, the recommendation is to go lower so they start to dissolve. And what's important, I think, is that this idea of managing gout is very similar to the sort of way we manage diabetes. You know, we use different ways, in lifestyle plus drugs, to get the blood sugar at a certain level. Well, gout should be managed in a similar way, where we use lifestyle and drugs, and we'll talk about that in a minute, to achieve a target uric acid level. So what do we need for this gout prevention? Lifestyle approaches are useful. You've got to be careful about how much alcohol you use, and especially beer, because beer has a double whammy. It's got a lot of purines, plus it stops the kidneys removing the uric acid. With diet, it's much less clear, because in Australia, fewer and fewer people are having huge amounts of red meat, shellfish, pate, kidneys, and so on. So certainly people need to be careful with how they eat, and the alcohol. And also, the thing that people don't often realize is the artificially sweetened drinks with the fructose. And this is what Helen was talking about before, that there is this idea of gout being diet related, that if you stop eating meat, fish, and stop drinking, you'll be fine. And the gout is very much a disease of affluence and excess. And that has a major impact, because it's interesting that many people who have gout almost feel a bit embarrassed and feel that they're somehow to blame. But what we know is that lifestyle changes are always important to institute, but they're usually not enough to achieve target uric acid levels. And I think in managing gout, it's terribly important to move away from this thinking that you obviously got a bad diet and eating poorly and obviously drinking too much, and to move to making sure that there's a sensible approach there, and then move to the drugs, because that's really the only way to get down to the levels that you need to get disease under good control. So the drugs, interestingly, allopurinol or Xyloprim has been around and everybody's heard about it. It's very cheap because it's off patent, and for people that are allergic to allopurinol, we can use this other drug for Boxostat that's often been around, and most people respond to one of those two. Now, interestingly, there are these much more expensive biologics that you can see cost thousands of dollars, but there's no evidence that people do better. And it was interesting, the study about heart disease in the US suggested, oh, well, maybe every time someone has an acute attack of gout, we should be giving them a dose of this drug and a Kindra at $1,500 a pop, which of course is ridiculous, because you could achieve the same thing by just getting the uric acid down to a sensible level. And these drugs are just a one-hit wonder. They help at acutely, but you would have to continue using them permanently, and there's no evidence that they're any better. You know, if you respond to allopurinol, you're doing well. Now, one of the things that's a really tricky part of using gout, of treating gout, is that there's a paradox with gout. So you have an acute attack, and you need to let it settle down, ideally, before you start to use the gout preventers. Because what we find is that if someone's just recently had an acute attack of gout and you jump in with with something like allopurinol, it can make that gout attack grumble on and on and on, or even flare. Because what happens is that even when you start medicines like allopurinol, as the uric acid levels in the body change, you can actually precipitate acute attacks of gout. And so the way we deal with that is very effectively. We start the treatment with drugs like allopurinol very slowly. We start at a low dose and we slowly build it up. And also at the same time use something something to prevent acute flares of the gout. So this can be done very effectively. You're going to need to potentially be on allopurinol for a long time, because it's whatever, if your body is overproducing or not getting rid of enough uric acid, that's likely to be a permanent thing. And so by using something like allopurinol, you get the balance right. And so what we do is we ideally start, so typical dose of allopurinol in many people is 300 milligrams a day. And what we would typically do is start at 100 milligrams a day for a month, then go to 200 milligrams a day for a month, and then 300 milligrams, and leave the person on that. We would increase the dose about once a month, as I described, based on the blood uric acid level results. And this can vary how many times you need to see people. And it could be that you need 6 contacts over 6 to 12 months to achieve good gout control. Now, what we use to prevent the gout is often something like colchicine or Colgout, 1 tablet a day, or 1 or 2 tablets a day. Some people might use an anti-inflammatory, but the most common is just a little bit of colchicine, which is enough to stop the gout flares happening. And this will often need to be used for about 3 months. Now, I want to show you how effective uric acid lowering can be. This is a picture of some gouty tophi. You see this big one here. Well, after 2 to 3 years of treatment with allopurinol, this is what it looks like. And similarly, here's one here that's almost disappeared. And so if you leave this person's hand continue like this, what happens is that the skin breaks down, you get infections, ulcers, and in some cases people used to have fingers amputated. What we now do, unless there's bad infection or something like that, the allopurinol will do this. So it's pretty impressive. The other thing that's important if you have gout is to also make sure that you have your blood pressure, cholesterol, if you've got any diabetes, that gets treated. You do what you can about lowering, trying to deal with your weight, and also keep physically active. So use cardiovascular prevention. So how well is gout treated? There's a big focus on the acute gout pain because it hurts. And so we focus mainly on gout management. But interestingly, and it's not just a problem in Australia, it's an international problem, that really less than 40% of people who have those criteria that we discussed at the earlier have gout prevention started, and only a minority reach target. So why does this happen? And it's really easy to understand. I think there's quite a lack of clarity of what are we trying to achieve. And really, the key change in the last few years is that we need to reach target uric acid to prevent the complications and ongoing problems. Now, the problem with that is that it probably takes a few visits to the doctor over 6 to 12 months. And this is in a person who feels well, has no symptoms. And so this is a real impost on patients in terms of cost in time, because every time you go and have a medical appointment, it's, you know, it takes a long time. You have to go there, miss work, and so on. And also the cost in financial terms. So this is a recent survey done in Australia. They were the sorts of issues that were identified by patients. And interesting, general practitioners felt they had lack of confidence in managing gout, especially people have other problems like kidney problems, which are quite common as people get older. And of course, we see every day on the news at how busy GPs and how overburdened they are. And so adding extra appointments in people who are otherwise well and no longer acutely unwell is a real problem. So, you know, so who treats gout? Well, I think it falls between the cracks, because you need a number of contacts to get the uric acid to target. But as I mentioned, it's time. There's not enough appointments. Out-of-pocket costs might be $50 to $75 per appointment. So rheumatologists are, don't have appointments in private or in public. And of course, in private, there's the addition of the cost. We've just done a social media survey where when we analysed it, we had about 320 responders. We've got more and more people responding to the survey. But the preliminary analyses, well, the average age was about 23. You can see there's quite a distribution from 20 through to 80 of people responding. 85% were male, 15% female. We asked people, and people self-reported how many attacks they'd had, and you can see that there were a few people that only had 0 or 1 attack, but there were quite a lot of people that had quite a lot of attacks in the last year. We asked if people had had discussions about their uric acid, and about 2/3 had, 1/3 hadn't. We asked people how satisfied they were with their gout control. There were about 30% were satisfied or very satisfied. About 30% were very dissatisfied or very dissatisfied. And and then in the middle, you have this other third that were neutral. We asked if people needed help with their gout management. Only 20% said no. About a third said yes, and quite a lot had maybe. So this was self-report. And then quite a lot needed more information on how to manage their gout, 71%. So we need a better way to treat gout, and because this is a recurrent problem that is in the literature, people keep mentioning. And there was a very nice study done under the National Health Scheme in the UK, where they did a nurse-led care versus GP care and followed people up over 1 to 2 years, and found that the people were much more likely to reach target uric acid in the nurse-led versus the GP, 95% versus 30%. And this was associated with less flares, less TOFA, improved quality of life. Now, this is a really nice study, but when you do studies in clinical trials, people are always behave differently. And so we asked ourselves, can we replicate this in the real world? But also a limitation of this study was that people had to chuff off to the hospital regularly. So you still had these face-to-face appointments. So what we did was did a treat-to-target clinic, gout clinic, where it's all done virtually. And so what happened was that people that had gout, where the plan was that they needed a treat to target, we offered them to be in this, to have it managed in this way. And about 80% of people that were offered this took it up. And so the education was really focused on uric acid, and moving away from this idea that gout is a disease of excess and the stigma. The aim was to treat to the lower uric acid, to prevent flares. Blood tests were just done at the local pathology. We titrated the uric acid based on the blood tests, and then just, the idea was to follow people till they were stable and then just let them be managed by the GP. We found that there was a very good reduction in uric acid levels. And one of the things that I didn't highlight is that the patients we were looking at are really complex patients. They're less like this, the more simple, straightforward. Many had kidney disease and lots of other problems with their health. And so we found that in about 6 months, 84% had achieved their target. By 12 months, nearly 95% had. Now, to give you an idea, the number of visits that were needed, we looked, it ranged from 1 to 7 for the 6 months, and that was with a median. So 50% needed about 4 visits, and for the 12 months it was 6. 50% needed at least 6 visits. So what were the enablers? Well, this was very easy and convenient for people, in particular for people that had trouble with mobility and difficulty with access to transport. But it also is really convenient for people that have multiple appointments and work commitments. It's low cost because you're not paying for travel, and there's no money costs. Obviously, because this was a public hospital. We only used landlines and phones. People could use video links and that, but the focus really was just to catch people wherever they were. And we sent e-scripts and sent them their pathology slips, and there were text reminders. Barriers, is that people have to be able to really engage in the program, because really this is about very much patient driven care that's facilitated by a provider. So the potential benefits of this type of model, this can certainly be done in general practice, and it could be done by a practice nurse, but often GPs don't have access to practice nurses. And then the question is how you fund it in general practice. But this telephone model has the potential to be like a helpline, and it really complements the care. You don't really, no one wants to take over care of gout from general practice, but it is an opportunity to consolidate the messaging. We found that when we were talking to people every month, it really brings home the idea that we're focusing on the uric acid, so people are more informed and engaged. And it's possible to do this in a safe, convenient, low-cost way with long-term management and follow-up, ideally by the local doctor with a yearly uric acid and making sure everything's still okay. So what about Mr. Jones? So Mr. Jones had the gout. He's had past episodes. He's got moderate kidney disease and he's got nodules. So he's got nodules, so he needs prevention. So you can make the diagnosis on his history and examination. He needs something for his acute gout. So we would use 2 tablets of colchicine now, and then another tablet an hour later, and then tablets twice a day the next 2 to 3 days. Because he's got kidney disease, then the non-steroidal anti-inflammatory drugs are relatively contraindicated, and he might be better off having some prednisolone, just a short course to tide him over. He needs to be targeted to 0.3, the lower level, because he's got the tophi on his elbow, and he needs to make sure that his cardiovascular risk factors are optimized. So gout causes a lot of pain and suffering. It's not a benign condition. There's long-term joint and kidney damage and the risk of heart disease. Treatment in people with recurrent gout needs to focus on reaching target uric acid levels. Lifestyle changes are important, but are generally not enough to achieve this. Treatment is safe and effective, but hard to implement due to the need for concerted effort to achieve the target uric acid levels over 6 to 12 months. So it needs a few patient-doctor contacts. Now, this can be achieved with a model of care that uses telephone follow-up and blood tests done in the community. So that was how I wanted to finish, and I wanted to just acknowledge, you know, the rheumatology team that I work with, and thank you all for listening.
Flavia, that was fantastic and so incredibly informative. We've got time. We've got about 10 or so minutes, if you're okay. There's been some interesting questions put forward, and one that stood out for me from Julian, and I thought this was a really interesting question, and I'd love to get your take on it. Is there a pre-gout type condition or indicators like you get pre-diabetes?
So I think, so in some ways it's a little bit like, so with diabetes you do the blood sugar, but we don't just make a diagnosis of this based on the blood sugar unless it's very high for a long time. And so there are all these nice other tests that people do to capture how long that's all been up for. I mean, there's nothing comparable in gout. So people, you know, like for example, with the Alfred, I think our upper limit of uric acid is about 0.45. Now, you see that, and sometimes people are even have levels of 0.5, and it's controversial whether you just treat a high uric acid level. I think many, you know, and so it has, there has been some suggestion if it's a high uric acid level, maybe you should treat it as a cardiovascular risk factor, okay? But that's all up in the air. There's a lot of, you know, studies being done, but the reality is that often, like a lot of things, these problems declare themselves. So for example, you know, if your uric acid level is just over the upper limit of normal, you would just leave it alone. If it's getting very, very high, you know, and you're getting older, you might even bail and use but really the proof is if you get acute attacks of gout. And you know, there's tons of people with acute attacks of gout that don't are not treated.
And a follow-up question to that, the pre-gout question, is it common from your experience to have a patient that only has gout, no other health issues?
Well, that's often in the, you know, there can be, but you know, as we get older, you know, you've almost, so you know, once you hit 50, you might have gout, but there's not a lot of people whose blood pressure is really good, whose BMI is really good. Do you know, so there's lots of people whose key medical problem is just gout. But you often find that people, just like type 2 diabetes, is part of that metabolic syndrome where people also have blood pressure that's up and cholesterol that's up a bit, and you know, and you know, carrying a bit too much weight. I think people often have multiple problems. Now, if you have a 35-year-old turn up with gout, you know, you always check to make sure that there's no, you know, their kidneys are okay and that they don't have some blood problem, you know, where you're producing a huge amount of, you know, your purines and uric acid. But often that's in the setting of a family history.
Okay, another interesting question here. This is from Graham, is there any relationship with osteoarthritis, kidney stones, and gout?
Well, once you start, so first of all, those chronic diseases go up as you get older, and so they travel together. Now, if you get damage to joints, anything that causes any damage to a joint will make it more likely you get osteoarthritis in that joint. So if you're getting, you know, if you're getting recurrent gout and a little bit of slow damage to joints, then that will spill over into osteoarthritis in that joint.
Okay. All right, these are some fairly specific questions to end our conversation with. So Julian has asked, is gout related to mitochondrial dysfunction?
I can't answer that. I'm not
Unanswered.
sure. I'm
Or,
not sure. I
or
mean, I'm not aware of it specifically. You know, there might be something in the literature, some paper somewhere, but it's certainly not a major contributor to gout.
okay. Comment from Lauren, who is obviously one of our healthcare professionals joining us this evening. She's mentioned that she has a client that has gout, severe gout,
Yeah,
but no other symptoms at 40. The BP is fine, cholesterol's fine, bloods are good, doesn't drink much. In a situation like that, is that one of the types of situations you will see that the patient just in inverted commas, because it is
yeah,
a serious condition,
yeah,
has gout?
yeah.
Yeah.
Then that's a so that's the sort of person. So if a person, so this is different to what Lauren has described, but if a person turns up with one episode of gout, it's terrible episode, but they never have it again for years, you don't need to do anything. And you know, you might be tipped into treating if the uric acid levels are really high, you know, and might just tip you over, although that's not a criteria. But if Lauren has a client who's had you know, who's getting like 2 episodes of gout a year, and, you know, and the uric acid is high, and they're the sort of people that, you know, you probably, I would start allopurinol. You know, and I didn't go into this, but so allopurinol we use, yeah, look, that sort of person, if they're happy to go on to, you know, allopurinol is the way to go. I didn't go into great detail, but if the people are from an Asian background, then there is a genetic test where some people can get an allergic reaction to allopurinol. So we used to just use allopurinol all the time. Now, if people are from an Asian background, there's a genetic test that you can look at, that, and if the person is positive for that, then you just move ahead and use febuxostat. But in the majority of people, you just start allopurinol. Now, that person that's having 4 episodes a year, you would probably just need to introduce allopurinol very carefully with some colchicine, because that's the sort of person where, you know, they can, you know, you can sort of suddenly trigger lots of episodes, and you know, your aim is long-term control. You don't have to jump in quickly. And I've got to tell you another funny story. So when people don't understand how to use, what the aims of the gout is, we often see people who turn up to hospital or turn up to the clinic with bad gout that won't settle down. And so what they've done is they've got sick of taking the allopurinol, leave it in the cupboard, then get a twinge in their toe and think, whoops, I'm getting my gout. So they rush off and start the allopurinol, and then the proverbial hits the fan. And so that's so what we do is really just say to people, it doesn't matter if you stop your in the toe, yeah. So we tell people not to we tell people, you know, if you stop your allopurinol, you know, that's life, you know, these people get sick of taking tablets. But if you get an acute attack of gout, don't suddenly use allopurinol. Let that attack settle and then slowly reintroduce the allopurinol.
Excellent. Look, Flavia, it's been an amazing presentation tonight. You are amazing as always. And I think the fact that we had so many questions and so many people online engaged in this shows that there is a real need, as you said, for this education piece around gout. There is a need for people living with gout to be able to take control and manage it as part of their healthcare team, and not have their lives so adversely impacted by the condition. And I think what it's shown tonight is that it is a really serious condition, and it needs to be addressed, and people need to have access to the quality clinical information that you produce through your research and through your practice, as well as the support of organisations like MHA when dealing with gout. So on behalf of everyone online who are sending up lots of hearts to you and lots of claps, thank you so much for this evening. It has been wonderful. I've learned a lot, and I know everyone online has learned a lot. And thank you everyone for joining us. There will be a recording of this available on our YouTube channel. We will send out the link. So if you feel you've missed anything tonight, or you want to revisit some of what Flavia has said, feel free to jump on our YouTube channel whenever you want and have another watch of this. So on behalf of Musculoskeletal Health Australia, thank you. Thank you, Flavia, and have a wonderful evening.
Thank you very much. Good night.